So our next speaker is Dr. Keita Franklin. Dr. Franklin is a member of the Senior Executive Service is the National Director of Suicide Prevention for the U.S. Department of Veterans Affairs, Office of Mental Health and Suicide Prevention. Dr. Franklin serves as the Principal Advisor to the VA leadership for all matters pertaining to suicide prevention.
Okay, very well. Thank you so much. I'm also, is this turned on? Equally happy to be here this afternoon with these esteemed colleagues from the Department of Defense and SAMHSA and our nonprofit partners as well, and equally impressed by how packed the room is here. So I feel like the pressure is on to make sure we give the best content, and I also want to make sure I build on the existing work of Dr. Adam Walsh. You know, we hear a lot in the press, and it's absolutely the case that 20 veterans end their life by suicide, but I'm not sure you hear that 123 people end their life by suicide every day. And so it is absolutely, and you'll probably hear more about this from my colleague Richard McEwen, but it's the 10th leading cause of death in the nation. And so it is absolutely a serious issue and deserves all the work and the efforts that are going in to prevent it. And the important thing to leave this room is that it's absolutely preventable. There are things we can and are doing to get after the issue. And so I want to make sure I run down some of our veteran-specific data, building on the existing data that you heard about from the Department of Defense. Within our veteran population, I get asked the question a lot, are our veteran rates higher than our civilian rates? And I will just tell you, yes, 1.5 times higher. When we compare matched populations from veteran to civilian and non-veteran cohort, and I can tell you what we think about that and why that might be. Equally so, when we dig even deeper, you start to see some of the at-risk groups. And so I will tell you that for years as a social worker in the field, we focused a lot on what we called men over the age of 55. And I should have opened my talk by thanking the Men's Caucus for leading in this space and putting this this group together, because I'm so pleased that you all are taking a leadership role on a topic as suicide. I know you could take on many issues. And men over the age of 55 has always been an at-risk group when we've studied it out. But I want you to know in our veteran population that over the last year or two, and we've peeled back the onion on the data, we see that our highest rate is amongst 18 to 34-year-olds. And so this is a different way of looking at the data, and it tells us that we need to bring different solutions to the table when you're thinking about age demographics and what we know about the cohort of people that have come up through the military and are in that age group, 18 to 34. I will also share with you that we do continue to look at men over the age of 50. In part, we have more of them in the veteran cohort. And so that's also, when you look at our data, you see the raw numbers are higher over the age of 50, but the rate is highest amongst 18 to 34. It's just a small nuance, but just the difference between rate per 100,000 and raw numbers. So I want you to know about that. Also, an issue around females. Female veterans are, 1.6 times more likely than their non-veteran cohort matched counterpart. And maybe some of you that have been in the field longer might have heard this notion that men complete more, and that females attempt more. In part, men use more lethal means. And so when they're using a firearm, there's just often no going back, right? Versus medication, where we can make a save, or some other method. And so we have more male veterans, as they do on the DoD. We have a higher rate of females. Also, I want you to know some of the other at-risk groups that we're trying to dig deep on, and that is veterans that live in rural areas. I just offer that, and to the extent that some of you come from rural areas, that ties closely to access to means that might be more prevalent in some of those rural areas, as well as just access to services. So this notion of any and all manner of complication getting people into care can become a barrier. So when there's a long drive, when there's a long wait, and so anything that we can do in the VA to eliminate those barriers, we can and are doing. And so that's a little bit about our data. But when you look more holistically at the risks, I want you to know that the risks for suicide are sometimes similar to the risks for other ills in society or problems that you might think of. So when you look at the risks for domestic violence, or for substance abuse, or for child abuse, or for even sexual assault in some cases, the risks can sometimes be quite similar. And when you look at things that protect against those issues, again, there's a family of buffers or protective things that are also quite similar. And just one of the, I think, most exciting things about working with the veteran population is the notion of peer support. And you heard about it from my colleague that they like to rely on one another. This sense of belongingness is a big protective factor. So if you walk the dog backwards from that, isolation is a big risk factor. So when we can bring veterans together and make sure they know that they continue to have a mission, a purpose, a sense of belongingness, and that they matter to one in each other, then we know we're doing the right thing. Equally so, I fully am on board with Dr. Walsh's comments about mental health. When we look at our data, it is interesting when you can look across 3 federal agencies and see that the data is quite similar around this issue. About half have a known mental health issue, and about half don't, which is why we call for what we call like bundled strategies, like certainly continue to invest in mental health, which the VA has done. Hopefully we can talk more about some of those, whether it's telemental health or opening up access and things like that. But also we as a nation must invest in all sorts of capabilities that come together with mental health to really get to a point where we're making a difference in terms of a reduction. We've most recently, I want to talk to you a little bit about what we're doing about it part of the story, and that is because we've just kicked off these things called Mayor's Challenge. I don't know if anybody's heard of them. The VA has had great success with this before my time in the homeless area. So we're sort of adopting a best practice from that field, but we are working with 27 mayors and cities. And what it is we bring them under the direction of Richard McEwen, who you'll hear from, in partnership with DOD. We bring them in and we just teach them the best evidence on how to get a reduction in their community, because it is really a local issue. Like preventing suicide it's a person-to-person sort of issue, and they will do it the best locally. So we bring them in. And we bring in all of their movers and shakers in their communities who get after suicide, and we train them up on making sure that their messaging is right, that their peer support is on target, that their mental health is evidence-based, and that they're working with their media properly. And we just train them up, and then we work with them throughout the week on a local plan. What does your local data tell you? Who are your local influencers for getting after this issue? And then what are your measures of effectiveness over time? So 27 cities are doing this, and now you'll hear soon. I think that we're close to releasing it on a press release. It's probably okay to share. We have 7 states that are now coming to the table, and so we're moving out with a governor's challenge. I have a test to myself at some point to memorize these 27 states and 27 cities and 7 states, but I have my cheat sheet here should anybody want to know what the states are. But we're pretty excited about that because we think when we're at year 1 and when we fully implement it and get the folks trained and they get intensive technical assistance from SAMHSA over time, that we'll start to see the reduction not only in suicide but in other high-risk behavior in these communities and cities. So I'm pretty excited about that work. Equally so, we do have a strategy. Our strategy, which we're passing out, and there's a placemat that I see some of you have that is sort of the one-page version of the strategy. Know that the strategy is not the VA's strategy. This is our nation's strategy for preventing suicide. So the idea is that you could pick it up and like you could look through it and do something, or you could do something. You'll see some call-out boxes like, what can I do where I sit? Because it is truly a national issue. And so the strategy is also built off the national approach where we have a number of goals. And one of the things I want to draw your attention to in the strategy is that we have a focus on building partnerships. We have 60 partners in our portfolio right now that we are matched up with. And the thinking behind this partnerships, I call it with my team, like we're trying to just crawl all over this space so that the partners are then equipped to do work with us and for us. We know that VA must lead and that it is our responsibility to prevent veteran suicide. Absolutely, that's our going in position. But when I can have an employer that employs the most veterans, take our training called SAVE, which is available online. I can get it to you if folks are interested. But if I can have them take our training and help us prevent suicide, if I can have them pass out our veteran crisis number, if I can have them develop peer mentoring models in their workplaces, if I can have them make sure that they're helping their veterans get access to health care when and where they need it, where they live and thrive, that's when I know I'll be doing good work. Just trying to shift our thinking away from a model that says, let's sit in our hospitals and wait until people come to us, to a model that says we're going to take it to them, like kind of like take it to the troops, move the programming to places where veterans live and thrive, and have many entities involved, vice just our own selves, is the forward thinking of what we're trying to do. I hope people are familiar with our campaign. It's, I think, the DoD and VA's joint campaign around Be There. If you haven't, it's hashtag Be There. Put it in. You should be able to pull up our website and all of our resources. As well, if I'm looking for my time clock. If I'm okay, I want to tell you too about ReachVet. We have this capability where we're doing predictive work in our hospital settings. And what it is it's a mathematical algorithm that maps about 160 variables. Each variable has a weighted value, puts them into an algorithm that then points to whether or not a veteran is at risk. Things like, have they missed an appointment? Are they diagnosed with opioid abuse? Have they missed more than one appointment? What is their pre-existing health factors? Once that goes in, if it tells us that one of our veterans are at risk, this is the beautiful part of ReachVet. We then call them and do these outbound calls to just coach them right back into care. And they have a set script that they use. It's not as basic as this, but it pretty much gets after, like, we've reviewed your medical record and we're worried about you. We want you back into care. You're one of our own. You're our vet. And we just coach you right back into care. We just did first one-year evaluation of ReachVet. It was rolled out well before my time under the leadership of Dr. Caitlin Thompson. And this is just an unbelievable capability because it just provides another data point when you're trying to save veterans' lives. And the first year evaluation, we looked at it across all causes of death, not just suicide. And we see that people that are identified as at high risk, as your sort of scientist in the room, independent variable, and your dependent variable, death, we see that you are more likely to have life and to live, the all causes of mortality. Have you been in ReachVet? And we were able to reach you. Part of why I think that capability is so important is just that what's at the heart of a lot of the suicide prevention literature is caring outreach. Such a simple capability. Calling a friend, caring outreach. And so we this year have also implemented a similar model in our emergency departments. When people come into the ER, they are at high risk. And I've even read literature that speaks to the fact that the very visit in the ER escalates them more, right? So what we're doing now is when they leave the ER, we're doing caring outreach. And it's a phone call, and it's, I know you were in our ER recently, and oftentimes people will leave the ER with appointments and things and follow on, and then it gets clumsy and bumpy, and did they really make those connections? Any of you that have worked in an ER, you just, you worry when people leave you if they're going to get connected to all of this. And so important to know that when they're leaving, they're going to get a series of phone calls with a script. And so I'm looking at my fellow. And so I'll close there, but know that that I so appreciate everyone's attention to this issue. And I can't wait for you to hear from Dr. Richard McEwen as well and see how all of this sort of maps together across the federal enterprise. So.